Welcome to the WRI, otherwise known as the Women's Research Initiative on HIV and AIDS. This is our 2026 version of the program, and we are absolutely pleased to have each of you here. We are going to be interrogating today, living with and treating HIV for a lifetime. So we're focusing on women lifetime survivors. And there we go. So a little bit about the WELL Project for those of you who may not be familiar. We are a nonprofit, and our mission is to change the course of the HIV/AIDS pandemic through a unique focus on women and girls across the gender spectrum. We do this in several different ways. The biggest way is that we leverage technology to improve health outcomes. And our focus is on education and information, community support, advocacy and leadership, collaborative engagement, and women-focused HIV research. And I'm going to be talking a little bit fast, so I apologize in advance because I want to get us into the meat and bones of our presentation. And so just a quick note on gender and language. The WELL Project has, as long as we've been in existence, advocated for the importance of gender and language. And so when we say that our efforts are focused on women across the gender spectrum, we mean any woman who identifies as such. And so we celebrate and uplift all of our community members. And we work with stakeholders, and I want to emphasize this part, to encourage the use of first-person language, which is critically important. And we want to discourage the use of stigmatizing language. For the purposes of this, an example is avoiding words like HIV infected, or in the case that we're talking about today, the preferred language for folks who were born with HIV or acquired it early in life are dandelions or lifetime survivors over some of the other language that is traditionally used. So the WRI was founded in 2003. It's a multidisciplinary and multi-sectoral effort dedicated towards identifying gaps and recommending solutions in areas of HIV and research policy that are of significance to women that are living with HIV. And so every year we bring together a group of folks such as you who are here in the room, and we take a look at how we can improve, change, influence policies, academics, things like that, to make sure that women are able to thrive as they live with the virus and thrive through their journey. We want to acknowledge our for all of their hard work and all of the effort that they've put into this thus far. That is Allison Agwu, Judith, Laura Gale, Kate Powis, and Andrea Weddle, along with members of the WELL Project team. And so this year, again, we are interrogating folks who have been aging with HIV since birth. And so we're looking at the journey of women lifetime survivors, and I would say the journey and the wisdom. And so our virtual programming this year is going to be 3 sessions, of which you all should have received your invites to. This one today is living with and treating for a lifetime. Coming up next, we'll have sexual and reproductive health, and then finally, accelerated aging and comorbidities. So we are in for quite a ride, I think, looking at things that should be examined. Again, I am your moderator. I did not introduce myself. I just jumped right into the slides. I have a bad habit of that, so I apologize. I am Bridgette Picou. I'm the stakeholder liaison for the WELL Project. I'm a nurse by trade and a woman with lived experience. We also have Tia Morgan-Revere, Ezer Kang, and Allison Agwu, who also may take a little second to introduce her as they come in. So I want to take a second to thank them for their time and efforts in making this webinar what it will be, and y'all are in for, I think, what will be really informative and a great use of your time. So we appreciate it. So today's session setup is going to go, we'll have presentations first hour, and then we will move into our Q&A. As of this moment, only the panelists have the ability to speak and present and all of that. But at the end, when we head into the Q&A session, everyone will be promoted to a panelist so that you can come off camera and off mute if you so desire. I would ask that you use the ranger so that we can keep track of that. You can also submit questions through the chat and through the Q&A. We'll be monitoring that. So if you have a burning question and you don't want to forget it, please feel free to enter it into the chat or the Q&A. The webinar is being recorded in its entirety, and the webinar will be recorded and will be publicly available after the fact. However, we will not include the Q&A session, and that is to give folks the comfort of being able to speak freely and to ask questions, meaningful questions, and have input into the conversation without fear of what it's going to sound like after the fact. So just keep in mind that the Q&A portion is not going to be recorded. There'll be a short evaluation at the end of the session. And so we're going to ask that you complete that for us to inform future programming and make sure that we're doing a good job. And as I already said, hopefully you've already introduced yourself into the chat. And so our agreements, I'm going to ask, it's not on here, but I always ask for attention and your intention in this space. We want to make sure that we are focused and bringing the best of ourselves as we look at what can be delicate conversations and subjects. And so participation, we would like for everyone to engage. We encourage you to express yourself and say what you feel. We definitely want to use I statements. And then mutual respect. And remember that everyone is coming from a well-intentioned space, even though it may not be an experienced or well-informed space, right? We want to remain open-minded to new ideas. And then we assume good intentions and also attend to impacts. So I think everyone in this space comes with excellent intentions. We all make mistakes, and so we want to give grace for that. But we also want to attend to what may be harmful so that we can move forward and not have that stuff hanging over us. This slide is some of our resources where you can follow us and find us. These will be available after the webinar and through any one of our team members if you have other questions about that. The QR code is for our newsletter. If you're not subscribed, we encourage you to do so. We do not spam you. And so with that, I'm going to stop sharing my screen. I know I ran through that quickly. If you have questions, please let me know in the chat or if something wasn't clear. And at this time, we are going to jump right in. I'm going to turn you over to the amazing Allison Agwu.
Tell me which version you're seeing at the moment.
You're good. We are on your first slide.
Okay, awesome. All right, so hello everybody, Allison Agwu here, Professor of Adult and Pediatric Infectious Diseases at Johns Hopkins in Baltimore, and I run our Pediatric Adolescent HIV/AIDS program as well as our Young Adult Transitions program. Really excited to be part of the programming today, but also this whole series leading up to the WRI. So briefly, these are my disclosures. And then to add to what Bridgette said, want to make sure we do some level setting. That's a Bridgette term to make sure that we're all on the same page in what we consider the lifetime survivors, which is our preferred term. We oftentimes hear about long-time survivors, which are people who have been living with HIV for a long time and some, since prior to the era of HAART. But lifetime survivors are a subset of the long-time survivors. You may have heard the words dandelions. You've heard people say early acquired HIV, but it's inclusive of multiple populations of individuals who've acquired HIV early in life, either around the time of birth or through transfusion or early in life in the first decade of life. So I always show this just to kind of frame the first pediatric cases of HIV, back with first reported in 1982 to 85, with the first actual individual lifetime survivor born in 1977. And that's was after we saw the series of other populations acquiring HIV, and then babies were first reported in actually a publication in 1987. The large majority of those young people were below the age of 2, with a spattering that had declared themselves or become diagnosed all the way till 13 years of age. We have seen individuals later than that, but just this publication only covered those 13 years of age. And the large majority, about 70% of those young lifetime survivors had already passed away by the time that report came out. I always show this. If you've seen me speak before, you know I like to show the framework in terms of how far we have come, because it's important to celebrate how far we have come in terms of from the first infant being born with HIV to the advent of AZT, which prevented acquisitions, to protease inhibitors, to where we now have, one pill once a day or one shot, or even cases of cure. So just to say how far we've come in the 40 plus years. And for the bigger epidemic, meaning beyond lifetime survivors or long-time survivors, we know that the progress has led to an increase in life expectancy for individuals who are living with HIV, where it used to be that it was life expectancy was 32 years without any ERT, and now with treatment, life expectancy has exceeded. And this publication is from 2013. There are updated ones which show later or longer survival, but not as an awesome graphic as this one has. I think it's really important to just say that Americans in general have many issues, right? We are all having the number one cause of death include heart disease, cancer, unintentional injury. And those are, before you get to HIV, Americans have some of the sickest populations among developed country. And I have that in air quotes. And just to highlight where that is, and has been unchanged over the past decade or more. And lots of that is associated with chronic inflammation. And chronic inflammation is associated with everything from cancer to metabolic disorders like type 2 diabetes, Alzheimer's, cardiovascular disease, and musculoskeletal disease. And that's for all comers. When you look at HIV itself is an additional, I like to think about it as a highlighter. It adds additional inflammation that then can increase the risk of cardiovascular disease and many of the age-associated diseases, where we're seeing an acceleration or a speeding up of those aging processes, again, related to HIV itself, but also related to medications and the immune activation and inflammation that happens in the body. And so when you think about it, you have HIV, which has increasingly, we're seeing more evidence of non-AIDS defining conditions associated with HIV. And you see those here: heart disease, kidney disease, liver disease, and others, cancer, cognitive decline. And these are also diseases of aging as well. And so aging with HIV, you overlap the two of them together, and then you add the addition of medication toxicity, and you see the increased probability of comorbidities in individuals who are living with HIV. And oftentimes we think about that when we talk about the graying up the epidemic, it's often really older individuals above age of 50, which the large majority of individuals, or about half of individuals, live with HIV over the age of 50. When you compare comorbidities for people who are living with or not living with HIV, what you see is that for those who are living with HIV who are in the dark gray bars, there's just higher prevalence of really all the conditions. So everything from multimorbidity, meaning more than one condition, but you see cardiovascular disease, hypertension, higher rates in comparing one versus the other. Importantly, we have to think about life expectancy, because I told you that in a prior slide that we're seeing people living longer, so longer periods of time once they have a diagnosis of HIV. However, lifespan does not equal well-span, and you're seeing that people are living longer, but they have higher amounts of comorbidity. So they're living longer, but those years of additional living are associated with or having comorbidities as well. So comorbidity-free survival is less. And so what you can see overall in the blue is without HIV infection, the life expectancy again, and this is again older data, but good slide, and then with and without HIV, and then the comorbidity-free years is less or fewer for individuals who are living with HIV. Here, I also want to show just what you see here on the left of the slide. I think it's still your left. You see when you look at the age ranges where people died with a diagnosis of HIV, what you see is a greater proportion of people, of those who are dying, were younger ages. And you're seeing more people who are dying are now older. And so that's represents the survival that we're seeing, which is good. So that being said, I'd like to turn to, because this is about lifetime survivors. So let's focus on the lifetime survivors. And so we've seen significant advances. This is, and I should highlight the term we want to use as lifetime survivors. I use the data right from the CDC, and the labels perinatal HIV infection. So this is infants born with HIV in the US between 75 and 2020. And what you see with those incredible advances is fewer individuals just being born with HIV, US, corresponding with fewer individuals having an acquired or AIDS-defining diagnosis, so fewer young people with AIDS-defining diagnosis, so fewer who have died. So that brings us to where we are today. And I say today, but this is 2017, and this is where this last data was presented by the CDC, showing about half of individuals who were lifetime survivors were in the 13 to 24 age range. So I age advanced this a little bit. Some have seen the slide to say that means we now have more folks who are now in the 25 to 34 and the 35 plus group. So an aging epidemic, which is reflecting that survival. I see hearts and think some of these young people are on this call. So this is where people who are living with perinatally acquired HIV are living, or lifetime survivors are living. This is 2023, including in Maryland, my own state, which is in the dark green, where we have a higher rate than some of the other states. And you can see many of the EHE states also reflected here. So to pause, many of our lifetime survivors are thriving 100%, doing really amazing things, pushing the envelope from advocacy to all kinds of things. And it's important to celebrate. But it's also important to highlight that many of our lifetime survivors are not, and we have lost some incredible people, even advocates. And it's important to talk about what we're seeing and why. All right. So to frame the stage, so lifetime survivors, I don't have to tell this group, they have unique considerations, and they're aging, and so I probably have to change this figure. We have few older looking people, but this based on being mostly youth. So we have neurocognitive delay and dysfunction. We have comorbidities, which we talked a bit about, hypertension, diabetes, and we'll talk a bit more about that. Some have had advanced disease immunosuppression from way back in the day, and some have it now. There's delayed puberty and short stature. There's a lot of mental health, anxiety, depression, PTSD, substance use that accumulates. There's treatment experience of various extents, and we'll talk a little bit about that in the other slides. Treatment toxicity and trauma. So you could have one pill and still have trauma from that one pill. There's treatment fatigue, same thing. One pill, one shot, still tired. Resistance, various amounts of resistance, again, which we'll talk about in another slide, and complicated ART, meaning to deal with the resistance, to deal with side effects, etc. ART could potentially be complicated. But this is the medical piece of it. I really want to make sure we highlight the other pieces, the logistic barriers, insurance, or childcare. Insurance, I cannot underscore with what's happening and the changes in insurance and how it may impact people's lives and what they have access to. The support systems, whether those that due to death or loss or just change in family and support infrastructure. There's poor adjustment to illness and illness status, efficacy, outcomes, social determinants, stigma, and more stigma, and then disclosure of HIV, sexuality, and the like, and others. And all of it on a bed of the quest to be normal. So I'm highlighting these other aspects in the gray that Ezer and Tia are going to speak to more, and really focusing my talk more on the medical complications and comorbidities that we are seeing. So why? I think we talked about the older folks and with the graying up the epidemic, but it's important to say that we're learning that HIV persists in survivors of early HIV. And whether that's from being in the womb or coming out of the womb or to now, there are multiple times where, and spaces and places where the immune system is interacting with the virus, the inflammation, everything from the maternal ART environment and what mom or birthing parent was exposed to what the infant was exposed to in utero. It's what the reservoir may be, where the virus can hide out and how that can be agitating to the system. And there's just lifelong ART, the pluses and ons and off of it, and the immunoinflammation or immunosenescence that can happen. All of those things are happening over the entire life course. And so how will lifetime survivors be impacted is a critically important thing that we need to be thinking about. But it's within a bigger context. So this is a graphic that's actually related to cardiovascular disease, but I thought really reflected what could be happening and how we should be thinking about lifetime survivors. So we're not living in a bubble. There's everything from the epigenetics and the epigenetics of what a person is built with, their underlying protoplasm. There's their interpersonal, their living conditions, there are all those layers and institutions and the socioeconomic policies. But there's also the exposures. Those things lead to exposure upon the system, and there are things happening entirely across the entire life course. So all of that leads to the allostatic load, right? Which is the wear and tear on a system or a person that can lead to comorbidities and outcomes. And let's talk a little bit about the drugs. These are all the agents that have been, I may have missed this, maybe a few more, but the timing of the agents that have been approved for treatment of HIV over the time course, from the time they first became available and how they then fall on the timeline of HIV, including the more recent ones in cabotegravir, islatravir, and the other ones are now available. And this slide just highlights some of the things that we know now with years of using some of these agents and some we don't use anymore, and how they impact the body. Everything from the gut and the things that we can see to the things that we cannot see, whether it's liver fat or what have you. So how is the impact different for a lifetime survivor? How is the impact of being exposed to something in utero impact you now 30, 40 years later? What happens in development and developing in the space of an ART? What happens in puberty, in menopause, basically over the life course? What are those impacts? And it's important to highlight that evolution of ART strategies has happened. Everything from being no ART, where we just didn't have anything, to serial monotherapy, AZT, then what have you, sequential one drug after the other, to the hit or hard, hit early, to we should wait till we have something to start, to we now start everybody on as soon as we can, right? And I highlight those who may be in the crowd who have seen the serial monotherapy and adhere to that, and that highly adherent to single monotherapy is part of why they may have multi-drug resistant HIV today. And so what is your birthday and where do you fall on this timeline may explain or show lead to or correlate with what kind of resistance you may have and impact what treatment you may have, as well as what inflammation outcomes you may have. So increasingly, we're understanding about the long-term morbidity of HIV, plus and minus the ART. This is an old graphic that I like to show because it really highlights this from Ron Hauser and colleagues from back in the day, showing how in the teal were the sort of HIV and AIDS defining illnesses and opportunistic infections, and how even by 2006, they had decreased in likelihood as we had advancements in ART and the like, and we saw sort of more non-AIDS defining conditions increasing. So we know cardiovascular disease, malignancy, the medication side effects, the metabolic abnormalities, CNS, long-standing inflammation continues even in the setting of suppressed viral load. And then what are the consequences at a decade, 2 decades, 3 decades accumulating? This is data from Ann Nealon showing sort of the mortality and the incidence of conditions or CDC or AIDS defining conditions in individuals who are lifetime survivors, showing that those who currently had lower CD4, not on ART, were more likely to have mortality or morbidity related to their HIV, and they were more likely to be seen in the older individuals. Now, this did 7 to 30 years of age at the time. And these are what the comorbidities were. So they were CDC events, they were bacterial infections, they were STIs, they were mental health, they were GI conditions, they were metabolic and bone abnormalities. But that stopped at 30. And this was data actually it included facts data as well as impact data. And so had younger age folks in that cohort. And so there's been subsequent data from Jason Haw and folks looking at the NA Accord, looking at about 500 youth, perennially those are lifetime survivors, 18 to 30 years of age, and looking in the adult cohorts. Important to look in the adult cohorts, because if we don't look in the adult cohorts, we miss people. And they looked at individuals who were seen and looked for non-AIDS defining conditions. And this is what we saw. High rates of diabetes compared to the general population, hypercholesterolemia, hypertriglyceridemia, hypertension, and chronic kidney disease. So this is one of the first studies showing in adult cohorts, looking for, one, do you have any lifetime survivors? Where are they? And what are their conditions? And forcing people to go back and look into the record and say, oh, actually, these unknown individuals we had, they're actually lifetime survivors. And here's what we see that their comorbidities are. So it's important to really think about the life course. So it's not just, I showed you the ART and what what exposures could have happened and the strategies that may have been in place, but the implications of adherence, even complete adherence to patchy adherence to non-adherence, to comorbidities that may be accumulating even in the setting without HIV, because I showed you as a general population, we also have a lot of comorbidities, where you get your care and how that impacts your care and the transition of care and how you engage. And then other risk factors, whether it's tobacco, substance use, alcohol use, STIs, weight gain, things that happen normally as people exposed to other things and modifiable conditions over life. And then what happens as you age over the decades? And we won't know unless we look and unless we ask. All right. So what's the life expectancy with and without HIV? I showed you this earlier on and talked about people who are not lifetime survivors. I think what remains is for someone who acquires HIV at birth, 20 years of age equals 20 years into the epidemic. So what will the life expectancy look like? For the first time, Ann Nealon and colleagues actually did this, looking at modeling data, trying to pull together different cohorts and different data, and tried to model different circumstances to say what would be the projected life expectancy for individuals who are lifetime survivors, and compared them with those with non-perinatal HIV or non-lifetime survivors, and then compared those without HIV. And what you see for males over here on the left panel, or A, is individuals without HIV at all. Remember, diabetes, hypertension, all of those things are still the comorbidities that they see. And so they had the longest life expectancy. And again, this is projected. Those with lifetime survivors actually had the next longest life expectancy, with about 10 years less than those who had never had HIV. And interestingly, those with non-perinatally acquired HIV had the most years lost compared to those without HIV. And you see some of the same pattern in females. Again, modeling data compared to actual real world data, but this is one of the first studies that says, well, let's model this out, and this is what it may look like, and went to some discussions about why you may see those differences in the different populations. So how will we know what's happening? So I think first is the voices of those adults who are born with HIV. This is a quote from Kim Kennedy, who said, "You all dropped the ball. We are literally fending for ourselves with no data and no research." And it was a call to action from her in a video. It's case reports and case series. This is my group showing a 23-year-old with a full obstructive heart attack, essentially, that was not believed and was on the floor for 12 hours or so before it was like, oh yeah, maybe he's actually having a heart attack. It's observational cohorts. I talked about NA Accord, where there was this other group in their list, in their data, and we said, well, of that other group, do we know who are perinatally acquired or lifetime survivors? And they went back and looked and found 455 of them to then get their stories. So if we don't interrogate, we won't know. It's longitudinal cohorts. We have a Hopkins cohort, there's a FACS cohort, and with changes happening to that, IDEA, NA cohort, other cohorts, and many more, trying to tease that out. And we need to push for them. It's interventional studies. It's including lifetime survivors in those interventional studies of medicines, of strategies, of approaches. It's modeling studies like the CPAC study that I showed you before. It's important to say, why I show this, and sometimes I acknowledge that it could be triggering when we're talking about morbidity and mortality and what have you, and what can we do? And so acknowledging you see something, you say something, and lifetime survivors are much bigger than the viral load. So there are actions that can be taken now. So it's prevention, it's lifestyle modification. We know smoking cessation can improve survival, decreased risk of cardiovascular disease. It's diet, it's exercise, it's knowing your family history and knowing what are the other non-modifiable things that you may put you at risk that we can address. It's stress reduction, it's vaccines, it's medicines, including preventative medicines. It's adherence, it's optimizing regimens, it's all of the things, but it's also research and advocating for research and advocating for care and outcomes and support and Medicaid and Ryan and White, and all those things are all a part of what needs to be done to optimize lifetime survivors' survival and outcomes. So with that, I'll stop and acknowledge first the lifetime survivors, and then my whole team and funding and support for all that I get to do. And thank you for your attention, and looking forward to talking.
Woohoo! Thank you, Allison. Let's, hearts up, fingers up, thumbs up. Thank you. Thank you. We're going to go through with all of our presenters before we start in on the Q&A, folks. So just so you know, Allison has given us a fantastic kind of medical overview. And now, as we move into Ezra's portion of the presentation, he's going to talk a little bit about the relational impacts of living with HIV for a lifetime. And so, Ezra, I turn it over into your capable hands. Thank you so much.
Great, thank you. Let me just orient myself with the slides here. I'm sorry. And of course, you had to have me follow Allison, who I can listen to for an entire day. So thank you for putting me on the spot. I guess my only response to Allison is what someone put in the chat. Dang. So thank you for that. Thank you for that presentation. And also thank you for the invitation to share a few of my reflections on working with lifetime survivors starting in New York City. You were to tell me when I first started as a newly minted psychologist at a pediatric HIV clinic in Harlem that I would talk about or present on lifetime survivors, I never, ever would have believed anyone who might have even suggested that. Now, why is that? Well, we all expected a very short-lived narrative of children who were born with HIV who weren't really expected to reach adolescence, young adulthood, or even older adulthood. That someday pediatric HIV clinics like the one many of us have worked in or has been involved with would be obsolete. But this whole Lazarus effect surpassed many of our most optimistic expectations of when these adolescents started to transition into young adulthood and now to adults. But time didn't stand still. We all know that as many of the lifetime survivors started to earn their diplomas, they started to cash their first paychecks, or they decided what to name their firstborn. The HIV epidemic, in many ways, grew up with them. Rather than to go through the developmental stages of childhood, adolescence, and adulthood, the HIV epidemic grew up, its identity morphed from early prevention in the 80s to treatment and to its anticipated eradication by UNAIDS by 2030. So apparently we are perhaps years away from complete eradication of HIV. In other words, as adults, as lifetime survivors navigated, let's say, 4 developmental periods, the epidemic also spanned nearly 3 decades of treatment innovations, tireless advocacy that many of you have been involved with, and public health wins. Many lifetime survivors lived through these years of the epidemic. So how can these historic frames of the epidemic not affect lifetime survivors? The journey was best summed up when a youth once told me, people always ask me what it's like living with HIV. Hell, I don't know what it's like not living with HIV. But you know what? Through all its different changes and iterations historically, the epidemic has never outgrown one thing. And Allison kind of alluded to this before. It's the stigma that's attached to living with HIV. And in the United States, especially living with HIV as queer, Black, brown, trans, or someone who injects drugs. If you notice, children who were born with HIV did not make this list, at least not yet. But many of us know that this did not leave lifetime survivors unscathed. Because in the US, HIV is commonly situated in context of social and environmental urban deprivations for the most part. Living with perinatal HIV cannot be decoupled from, let's say, neurologic or behavioral effects of prenatal cocaine exposure, or family vulnerabilities, or environmental shocks. Authors Morales and Bach describe this confluence of all of these factors as the full plate syndrome. You have a plate that's full of these vulnerabilities, and HIV just adds to it. It's just another card stacked against them. We suspect that this mounting plate will take its toll on their mental health over time. Some captured it well when they described the pediatric HIV clinic in Harlem where I worked, that over the years, we have turned from a medical program with mental health support to a mental health program with medical support. But as lifetime survivors transition from childhood to adolescence and to young adulthood, we mentioned before that the epidemic also grew up and also developed What I want to reflect with you this afternoon are how did the epidemic grow and evolve historically? What were the epochs or the historical frames and periods that the HIV epidemic that we have seen undergone in the US? And how did these changes, how did these shifts affect people who are living with HIV? We're going to talk about 3 shifts. One is what I call stigma transformation, the transition from innocence to culpability of acquiring HIV. The second historical frame is what I'm terming as treatment innovation, where it goes from an epidemic of crisis to now an epidemic of chronicity. And lastly, prevention science evolution, where it goes from self-protection, how do you protect yourself from contracting HIV, to now, how do you shoulder the responsibility of safeguarding the public? We're going to go through each one of these historical frames and to see how it may have impacted lives of longtime survivors. So the first, stigma transformation. As adults adapted to different treatment landscapes, the innocence that society once ascribed to them for contracting HIV at birth, it quickly dissipated, it quickly changed, it faded. As children, they were mostly shielded from public condemnation that was reserved for those less innocent or guilty, as society would deem, for contracting HIV because of their own doing. You notice the language and the narrative that I'm echoing right now. In fact, children with HIV drew sympathy from a large swath of society, even from royalty. A participant in one of our studies who was receiving services at Harlem Hospital recalled here that Princess Diana visited the Family Care Center at Harlem Hospital in 1989. But when she spoke to us as a young adult right now, she fondly recalled the event and said, "To think that once I sat on the lap of a princess, but now I ain't shit." I think that speaks a lot to this transition from we were once regarded as innocent, but as we grew and as we developed and as we became adults, that innocence was somehow stripped and we are now culpable. The comment highlighted the demonizing flip side of the word innocence, that in being sentenced as culpable for acquiring HIV and being rendered invisible or not mattering, because those belong to those in the guilty camp. This was uncharted territory for many participants because society created and arbitrarily assigned people living with HIV into groups. Some, like children with perinatal HIV, were valued until they weren't as adults. These groups have been divided into 2 groups, into what Donovan described as carriers of AIDS and victims of AIDS. One thing I've really always appreciated about WRI is the importance put on language. And I love in the beginning, before all the talks were introduced, the importance of level setting. But the language that was used by Donovan is that there's one group called carriers of HIV and the others were called victims of AIDS. That was the language. But I'm also wondering whether or not I am, or whether or not we're complicit somehow in reifying these categories. If when I ask students to look at the panel that you see here on the screen, and I often ask the students, everyone that you see in the picture is someone that is living with HIV. However, they perceive each one of these groups differently. Why? Because of these arbitrary categories that society has placed. Donovan further highlighted that groups most affected by HIV with the least power in society were negatively casted and described as carriers of HIV. This makes these arbitrary boundaries very destructive. Many participants, many long-term survivors in our study, they internalize these categories as adults and struggle with wanting to maintain their innocence while knowing it reinforced the culpability that society has assigned to others. How many times have we talked to long-term survivors and they share about disclosing their HIV status, but only if they say, but I was born with it. B-U-T, but I was born with it. What they're communicating is they have somehow internalized how society has categorized those who are guilty and those who are innocent. So disclosing their HIV status also serves to remind others and themselves that they were born with this. And in doing so, they acknowledge that they have somehow drank the Kool-Aid, that their innocence as children was weaponized against other groups who behaviorally acquired HIV. And they're trying really hard to shake this. The other historic frame is treatment innovation. We talked about stigma transformation. The second movement in transition is stigma innovation, going from crisis to chronicity. And I think this is best captured by this well-publicized, haunting photo that was published in Life magazine in November 1990 of David Kirby and his body wasted by AIDS, surrounded by anguished family members. This is the common picture that depicted the lethality of AIDS. It's a cruel death sentence. During this period, many children with perinatal HIV did not expect to live past their 10th birthday. I was sharing in another talk that my first mental health referral at Harlem Hospital in September of 2000 was to engage a 12-year-old boy who wasn't supposed to live past their new year, wasn't expected to live past the new year. That was my first referral as a psychologist. But this boy did pull through and lived to see his adulthood. The shift from surviving a terminal illness to managing a chronic condition that isn't supposed to change who you are or what you do, this has left many adults feeling disoriented, if you will. Although there was certainly a sense of reprieve, this relief was tempered by other nagging life stressors that are all too common when you're Black, brown, poor in the United States. We gather from several studies on young adults with perinatal HIV that one pill once a day, it's not necessarily going to make disclosing your HIV status any simpler or ensure that you have stable and safe housing or help you pay for your monthly rent or childcare. Monthly injectables, they're a game changer, but it's not going to help adults manage a familiar illness in a very foreign treatment environment that we often know as the adult ID clinic. All of these studies align with the prevailing takeaway that the challenges with treatment adherence that follow adults, these are challenges that follow them as they transition into adulthood. In other words, many have described it as these habits are rather hard to break. I had dinner with a friend 2 weeks ago, and my friend was sharing about how he's been doing with the new HIV meds. And he was sharing about someone we knew from the clinic who has been struggling medically. And we were talking about how you can somehow, unfortunately and sadly, predict who is going to have difficulty with treatment adherence based on how we have known the patterns when they were children. In other words, these habits are hard to break, even if it is one pill once a day. Transitioning from 18 pills to one pill once a day, that transition for some or for many, the challenges of adherence, it's hard to break. And lastly, PrEP and viral load undetectability. It has somehow redefined HIV citizenship and what it means to live with HIV. Yes, many participants in our study described it as a promising game changer but they also introduced kind of like a new element of responsibility of taking medications, not just to stay alive, which is a narrative they were used to hearing as teenagers, but now to keep their sexual partners and the newborn safe. The last historical frame shift that I want to talk about is prevention science evolution. Over the three decades, the narrative of HIV has shifted from self-protection to public safeguarding. In the early 80s, it's all about focus on protecting yourself and being responsible. And if you contract HIV, it is because of irresponsible behavior. In other words, you brought it on yourself. So if you don't properly use a condom, if you don't properly engage, the language of the day was in safe sex or preventive practices, then you are responsible for bringing harm upon yourself. But now prevention science have now shifted from self-protection to public safeguarding. Okay. Since PrEP, many adults with many lifetime survivors shoulder the responsibility of not just protecting themselves, but more importantly, protecting others. Like, I want to be clear right now. PrEP has been a PrEP has been PrEP has been a welcomed innovation in so many regards, but the messaging and the narratives imply that people with HIV should be responsible when public welfare is entrusted to them. In other words, I like to think of it as this hierarchy, this hierarchical assignment of social responsibility to a designated group. Now, this has a historical precedent. For many of us, we remember the ACTG 76 protocol, where it was hailed as a landmark treatment that reduced the risk of maternal to infant transmission in 1994. But it also, but the narrative there, it focused specifically on mothers, and at the time, especially poor Black and brown women, as the source of infection. The dramatic reduction of maternal to infant transmission during that period of time, it was somehow shrouded by this critique that the ACTG 76 studies focused on the fetus and on reducing perinatal HIV transmission, and by establishing the problem to be solved as women's potential to infect others. The blame was shifted onto women of childbearing age. That if that that if your newborn was HIV positive, the responsibility is on you. And you had the opportunity to prevent it, but you didn't. That same flavor of narrative is lingering when it comes to PrEP right now. I also want to add that this whole idea of achieving viral undetectability, achieving and maintaining viral undetectability, has now been regarded as a sign of victory. Now, anytime you have victory, the flip side is failure. While failure to achieve undetectability may engender feelings of being dirty or being a threat to social order. Okay. A 32-year-old participant in our study kind of talked about this division, this divide between those who are undetectable and those who have not achieved undetectability. He said, for those who are not undetectable, it adds this extra pressure of not measuring up. In other words, these are the new markers of HIV citizenship. So in closing, historical narratives of HIV have profound intended and also unintended consequences on lifetime survivors. The way we frame matters, framing matters deeply. In other words, level setting is critical. Okay. In the US, the framing of pediatric HIV has shifted from innocence to culpability, from crisis to vulnerability, and now self-protection to public safeguarding. What are the new narratives that are going to emerge? If we know that historical narratives of an epidemic is going to directly shape the daily realities of of lifetime survivors, we have an opportunity to change the course of how HIV is talked about and communicated. I very much appreciated. Um, I was asked if I can kind of like change change the description of adults living with perinatal HIV to lifetime survivors, even for this presentation. Why? Because we value, again, how 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 narratives are framed, because we have seen that it directly affects those it directly affects the lived realities of long-term survivors. These shifts have contributed to both flourishing and languishing. It's not just languishing, it's also flourishing among lifetime survivors. And lastly, HIV stigma has a long-term effect, especially how stigma is internalized and its cumulative effects over time. So I very much look forward to the discussion and during the Q&A, and I look forward to that time. So thank you very much.
Thank you so much for that, Ezer. That's a really powerful look at some of the themes that go under discussed and under talked about. And so us having an opportunity to examine them here matters. So thank you so much for that. I am now going to turn us over to our last presenter, last but definitely not least, Tia. And I want to give Tia a shout out for being a superwoman because y'all, I'll let her tell you the good news herself. But the fact that she has shown up and is ready to show out for us today is a wonderful thing. So, Tia, I'm going to turn it over to you.
Hello, hi everybody. Um, as she stated, my name is Tia Morgan-Revere, and I am currently a researcher at the at the University of North Carolina at Chapel Hill, and I am a advocate and a lifetime survivor known as a dandelion. And I'm very happy and honored to be a part of this conversation today to share my experience that literally shaped my life growing up alongside and contributing to HIV treatment advances. So today I'm just going to tell you a little bit of my story and my point of view, but as well as what I think lifetime survivors have to go through and grow with this chronic illness. So if it won't. Okay. So who am I? Um, I am a very fun person. That's what I like to think of. But I was born as Teresa Shantia Williams to a mother who was a chronic drug user. However, I would like to point out now that she is extremely healthy and she is also a long-term survivor now. And she is married and has all this wonderful stuff going on with her. I still am very much contact with her. But I was born during a time when children were often not expected to live very long. My life expectancy was age 2, and my family and my medical team were hoping for milestones that many families took for granted at that time. Um, Around the age of, if you ask my birth mother, it was 2 days, and if you ask my adoptive mother, it was 2 weeks. But at some point, I was got into foster care with my now wonderful adopted family. I've been with them since birth, basically, and we've kept in contact with my biological family. With the help of them, as well as I would like to point out this lady over here. I don't know if you can see my mouse moving, but there's a lady in my graduation picture, my Auntie Diana. She helped us get in contact with the National Institutes of Health, and I am a product of research. I believe in research and the importance of research because research saved my life in many, many ways. When I was officially adopted, my name was changed to Tia Morgan. But sometimes when I don't want people to know my name, I tell them my name is Teresa for the fun, because why not? It's not a lie. With that being said, as you can see, I am still here today. I am a product of hope. I am not only surviving, but I'm thriving and I'm hitting all of my milestones. I have been undetectable since the 4th grade. I have been on many, many NIH clinical trials, including taking AZT and taking IL-2 treatment. And I've also had the fun side effect of AZT of having the enlarged heart. But I'm still thriving and surviving. I've earned a bachelor's degree in biology, a master's degree in biomedical sciences with a focus in microbiology, and my last degree is a master's of science in microbiology and immunology from the University of Chapel Hill. Um, I have enjoyed college. I have been a speaker through my lifetime as a teenager. I disclosed when I want to disclose back then. And I'm very grateful for what's called Camp Heartland. I'll mention them again later. Camp Heartland and NIH shaped my childhood, and they allowed me to feel normal even in the midst of all the crazy. With that being said, I am now a wife. I got married in 2023. I recently gave birth to my first child, which is down here in this picture here. He is currently with my husband in the living room, so hopefully he doesn't start crying. Um, and he is undetectable. It's amazing and it's awesome, and just to think about how far we've come makes me very happy. I'm also a researcher and an advocate, and I am someone that is deeply passionate about bridging the gaps between science and community. As I stated before, I currently work, well, maybe I didn't. I'm currently working as a researcher, research recruiter specifically, and outreach coordinator for the UNC Infectious Disease Clinic. That is also my own personal clinic, and I often will disclose to our patients there just to help them feel welcomed and loved and know that somebody there in the clinic truly understands what they're going through. Throughout the years, I've been featured in a variety of books, and I have also started a passion project of my own, especially due to the opportunities in the past 3 years. My patients that have been involved in other outreach communities have also gotten me involved in outreach community activities. So they caused me to want to create my own passion project where I started a social club called Beyond Red. And I'll talk about that a little bit later as well. So with that being said, what was it like growing up with HIV then versus now? When I think back about growing up with HIV, I think about routines. I think about medications, clinic visits, lab work, conversations about health and medications before I fully understood what it meant. Um, there was so many frequent visits that I was at the clinic every 3 months to every 6 months, flying back and forth from Las Vegas. Yes, I'm sorry, I'm originally from Las Vegas, all the way to Maryland for my medical treatment. And then over time, that transitioned to once a year, twice a year to once a year. And that was always something, and I always had to lie to like my classmates of what was going on and things like that. However, but now I've witnessed breakthroughs and what it's like to fully grow up with this. As a child, HIV carried a lot of fear and a lot of stigma. There was so much still uncertainty surrounding treatment and survival. And this early HIV diagnosis meant facing this uncertain future. Today, people with HIV can expect to live long, healthy lives and with proper care and treatment. You also can see the emotional impact of what it's like for people, the emotional impact of HIV had on families and communities. There was loss, there was silence, there was stigma. There was shame once forced on people, and now there are more people out there who are advocates speaking openly, me, myself included, educating communities and fighting for representation and understanding. Now, this is not to say that stigma does not still exist. Stigma very much still exists. But there is a transition that has occurred, which is really wonderful to see, at least from my perspective. Um, We've gone from very complex regimens to simplified treatments. When I was a child, I had to take multiple pills daily. I went from taking, I think I took Verisep, and I had to take it 3 times a day. So 3 pills at lunch, 3 pills at breakfast, and 3 pills at dinner. My poor, just a fun note, my poor elementary school nurse, I didn't know how to swallow pills when they first started me on pills. And I would throw up the liquid and the pills when it was forced down. You put in my applesauce, I figured it out, so I would not take it properly. And I had to figure out a way to take it. I think this is when my control issues became because I started chewing my pills as a child. It was kind of very gross, and my poor school nurse thought it was the most disgusting thing ever. So she taught me how to swallow pills by using jelly beans. And now I'm a pro at taking multiple pills, but now I only have to take 1 pill because I'm on Big Tardy. And it's just wonderful to see the complex regimens to such a simplified treatment and having the opportunity. When I disclose to our patients in clinic, I often have a tendency to say in a very weird way that if they're going to be diagnosed, this is the time to be diagnosed because they don't have to take as many pills. We have come such a long way. And if they don't like pills, most of the time they can get the shot. That's not always the case, which I understand as well. At the same time, I've had the privilege of, are you going to move forward? Sorry. I've had the privilege of watching HIV care evolve dramatically, not just in those complex regimens, but also moving from survival focused to quality of life focused. The conversations have shifted from simply staying alive to thriving, pursuing careers, relationships, and dreams without limits. Um, And those are very important. The shift is incredible to witness as someone who lived through both realities. A very scary time back then, I will have to admit. Knowing what, for me, I've been in hospital rooms with people with children that were like me, and knowing that they were in bed sick from the same thing that I was sick from, but they were way sicker than me, but it could have been me, was one of those things that I had to truly understand and mentally go through. Um, living with HIV over a lifetime involves the treatment and health and resilience. One thing I want people to understand is that living with HIV over a lifetime is much more than simply taking a pill every day. Growing up, many long-term survivors experience complicated treatment regimens that had various side effects. Um, they had to have large pill burdens, strict schedules, and side effects that could physically and emotionally be exhausting. As medications evolved, treatment plans often changed as well, requiring constant adjustment and trusting in the medication and trusting in the field. Um, you also have adherence issues. And you had people who adhered very well, and you also had people who adhered very badly. I fell in the middle. My mom would find pills in my pockets um, over time, um, and I would get fussed out. But luckily and prayerfully, I stayed healthy all this time. Um, Even I had adherence issues when I got to college. When I got to college, I went a semester where my mom would mail me my medications. And over time, she would wait to see if I noticed that she did not send me anymore. And this will go into something else about what it's like transitioning into adulthood. I just had to be responsible for my medication as well. So adherence is trying to remember that medication. It involves mental health, stability, access to care, which not everybody has, support system, again, not everybody has, and resilience through different life stages. You also have treatment fatigue. It's just as exhausting just to take it so much. And having to remember to take a pill every day is extremely exhausting. And again, I'm still not perfect. I still have my moments. Now I'm focused on my child has to take medication. So that's even interesting to make sure he takes it on time. Um, After decades of treatment, many people have experienced, as I stated, treatment fatigue, and this is just exhaustion. And there are moments where HIV feels less like a diagnosis and more like a constant responsibility that can never be fully put down. At the same time, HIV care has changed dramatically. We have advances such as U equals U and PrEP, have transformed the conversations from prevention co transform the conversations about prevention, stigma, and relationships and quality of life. And it is an honor and amazing to see and work in a clinic where I can promote both the U equals U and the PrEP. I often get asked, is my husband on PrEP, by the patients or about my journey? And I explain that U equals U is such an amazing thing to be. I did not know anything about our state laws when I was in college. I was living my best life. I educated people, but I did not make HIV education my main thing. I want to focus on being a college student. But as I entered my career now, I realized I could have went to jail for all of these laws and things like that. And the laws are not taught, which I think is important and should be taught more frequently. And as a person now who's truly involved on policy and things like that, I understand what could have happened when I was in college back then. So U equals U is a very important aspect, especially when it comes to laws, and PrEP allowing people to live healthier lives and more freer lives in a way. Um, you have to trust that all this transitioning and the medications will help you through each life transitions and things like that. Today, the focus is no longer only about survival, but now we're talking about long-term wellness, mental health, aging and relationships, parenthood, and living full and meaningful lives with HIV. As someone who recently became a mom, being able to experience pregnancy and giving birth to an HIV negative child is something that I once felt was unimaginable. And this is for many women as well. My mom stated that I told her I never wanted children, and I just never thought I would have a biologically related child. I always wanted to adopt. So being able to physically give birth was amazing. And I felt honored to be a part of that. And something to point out now is that I can best breastfeed, which is why he still has to take a little bit of medication, regardless of, um, even though I've been undetectable forever, he still has to take medication for 2 weeks. And if I continue to breastfeed for however long I breastfeed for. And that took me my entire pregnancy to wrap my brain around it. Transitioning from what I was used to what I now know. And being a scientist, but also being a person living with it is very hard to balance the two. So I was constantly asked, are you going to breastfeed? Are you going to breastfeed? Are you going to breastfeed? And I'm just like, let me wrap my brain first. However, I think that this shift from surviving to truly thriving is one of the most powerful parts of this journey. And with that in mind, as I stated, trying to wrap my brain around where we were and where we are now, this lends to the weight behind the diagnosis. Um, Living with HIV impacts more than just the body. The emotional and cognitive burdens often remain invisible, carrying the stigma through daily interactions, the exhaustion of constant health awareness, and the weight of survivor's guilt from losing friends and community members along the way, is one of those things that we have to that's consistently on our brains. Um, you have to, when you grow up carrying the stigma, it can affect how you see yourself and how safe you feel sharing your story with others. I learned early how much stigma can shape the way people view HIV and people living with it. There's anxiety around disclosure and fear of judgment. For example, and to Ezra's point, when I was a child, I was always told, oh, people are going to accept you quicker because you were born with it. But my mom made sure to make it very clear when I became a teenager, the difficulty and the importance of saying I was born with it, versus just saying I have HIV. Now, and so he was, to Ezra's point about innocence, the culpability is a very, still to this day, a very weighing thing. Um, what I like to say is I don't actually say I was born with it anymore because I don't like being seen as, oh, well, it's not your fault. I've been told that directly on more than one occasion. If people ask me more questions, I will happily share a little more detail. But I try to steer away from saying I was born with it unless somebody asks me or I'm telling more of my story because I just feel like that's unfair to those that were not born with it. It doesn't matter how a person acquired it. It just matters that they're living with it and how we should be supportive of them. Especially in my clinic, I try to make sure I put that point out. Um, Over a lifetime, we see that through these challenges, resilience emerges. Unfortunately, it's a good thing and a bad thing. We're resilient, but we have no choice but to be resilient. Um, Sorry. We learn to hold on to grief, and we have to hope together, finding strength in that vulnerability and recognizing that mental health is just as important as our physical well-being. These are the quiet victories of long-term survival. And sharing our stories creates room for connection, education, and healing. One of the things I would like to acknowledge is that NIH, unbeknownst to me as a child, had therapy. I was in therapy as a child, and I did not know that. I was I loved my psychologist. And to this day, we still are in connection. And it wasn't until I was about 21 that I realized that that's what we were doing. She was helping me through these things. I just thought it was somebody I talked to. So that was a very important thing to have as well. And then transitioning into adulthood is is very interesting. There's a difference between being cared for and learning how to care for yourself. Growing up means taking ownership of your own health journey. The shift from pediatric to adult care systems requires learning how to navigate healthcare, new healthcare environments, building relationships with new providers, and advocating for yourself in the medical setting. When you transition from pediatric care to adult care, can feel overwhelming. Building trust with these new providers while maintaining continuity of care is a critical step in this transition. For me, pediatric spaces were very supportive, family oriented. My providers knew me deeply. I've had a variety of providers that knew me my entire life. And now I have to find doctors here who are not specialized. And that also was a journey for me. There's often a strong sense of protection and guidance from your pediatric care, and now you have people who care, but they don't know you as well, is also one of those things you have to adjust to. It means learning independence and taking ownership of your healthcare decisions. Um, you are now all of a sudden managing appointments. Understanding medications, advocating for yourself, and navigating systems more independently, especially understanding insurance, which I still do not know, and refilling prescriptions, um, requires new skills. Again, my mom in college, it happened twice, the beginning of the college career and the ending of my college career. My mom was still sending me my meds, and I did not tell her that I needed my medicine. And she was like, "You haven't taken medicine in 2 months." Um, and she's like, "I need you to go look at your pills." And I think she was trying to teach me a lesson, but in a safe manner, because she figured that in those 2 months, nothing bad, I'm probably still taking something. But that was a lesson I learned, and I learned it the hard way. So that was a huge adjustment for myself. This involves building confidence and self-reliance and managing a lifelong health needs. Um, so slowly, it took me a minute, but I got there. Um, and then this transition doesn't happen in isolation. It is happening at the same time as normal life transitions of adolescence into adulthood. You have to learn how to speak up for yourself about treatment preferences, ask the questions, and advocate for your needs. Transforms you from a passive patient to an active patient, participant in your healthcare. And it just requires a lot of different focus that you didn't have before. At that time, you were still figuring out your identity, relationships, school, career goals, and independence while managing this chronic condition. So that really was a huge journey for me, and I'm assuming for other people in my predicament as well. And then relationships, identity, and community. HIV impacts relationships and identity in very personal ways. Navigating life beyond HIV means building meaningful connections, finding your voice, and discovering communities where you belong. Representation matters, and safe spaces transform isolation into empowerment. For me, disclosure in friendships and dating, this means choosing when and how to share your status, requires trust and courage. From relationships, present, each relationship presents unique considerations and timing and context. For me, I either told people very early on, not, relationships that I was looking for love, I played those very differently. But friendship wise, I either was very secretive or it was one of the first things that I told you about myself. My college best friend, a month into knowing me, I was at my birthday dinner with her and I randomly just told her, "Hey, I was born with HIV." And then I'm pretty sure I just made her feel very uncomfortable. But we've been tight ever since and she's been very supportive. And it was very happy for me. I have not had very bad disclosure moments. I've had people who say they were okay with it and then slowly just disappear, or people who just don't care and they stay in my life. When it came to the opposite sex and me trying to find love, I told, I figured out over time what was the best time frame for me. 2 months was long enough. 3 months, past 3 months, I start feeling like I'm lying and it's difficult to share. But I also used it sometimes to see if people would um, stay. So some people I didn't want to talk to, I told them more frequently. And shockingly enough, there are a lot of people that are accepting. And that was a beautiful blessing for to know. But at the same time, I also was like, dang it, you still like me. Um, I didn't want to talk to you. I don't like you that way. But um it's still, I think I choose to think about the blessing behind that. And that's also what I tell our patients. I'm like, it's a shocking amount of people that they might not think they'll be loved, but they'll still be loved. And there's people who just honestly don't care. Or when I say they don't care, it means that they care enough to be your friend, but they don't care that you have it and they want to support you. So I just try to emphasize that. And the picture down below is just one of my maternity pictures with my husband. And on his tattoo, it says faith, grace, and mercy. So that's one of my favorite pictures of our maternity pictures. And then this picture is also my friend who is my adult best friend, and just us laughing, and we stayed friends. Actually, I think that was the weekend I found out I was pregnant is when we took that picture. So I've had a very good support system. And then you have to still overcome internalized stigma. It can just be as difficult as overcoming external stigma. You have to unlearn shame. You have to unlearn shame, and this takes time and support. Recognizing your worth and beyond your diagnosis is essential for emotional well-being, and authentic connections. You also have to build community, and build community and connections. Finding safe spaces and supportive networks transforms isolation into belonging. Representation and advocacy creates visibility and hope from others. And again, Camp Heartland is a camp that was founded for children for children and their family and friends that had HIV and they helped shape my childhood and made me feel normal. And then recently, I've been involved with different outreach programs here in North Carolina, as well as Seeds for Healing. And they allowed me to do better and learn from there. I'm gonna try to quickly go through this because I know we're getting low on time. So, basically, from patient to advocate, I've always been an advocate. I've always been a patient and an advocate, but I've been much more of an advocate lately. One of my patients who is involved in a variety of different fields, she nominated me for the Leading Women's Society 2020 award a couple years ago, and this is me featured winning an award for basically surviving and being a lifelong survivor for more than 20 years, and also working in the field for more than 20 years. Research and storytelling is important, and I aim to bridge that gap between science and lived experience. I am a product of research. So again, research is just really important because research helps move the needle along. My work currently focuses on not only research, but recruitment and education. I try to make sure we have all the different studies from trying to understand HIV as a like how to cure it. I work on cure research, but I also work on understanding period poverty is an example that we're working on now with women. But I also am involved in our clinic advisory board where I do community engagement. I pushed for my community engagement part because that's what I feel is most important, is one of the most important things to do. We had World AIDS Day events as well at the clinic recently. And I just try to be a support person and help navigate our patients through where they're experiencing and where they are now, especially our newly diagnosed patients. I try to let them know, like, hey, we are here, and I have support. And if you want to meet other people, or have different people talk to you, I'm here for you and can get you there. I like to bridge the science and lived experiences. As you stated, I am a researcher from the lab bench, but I also want to create a community center in the future where I can help people understand what it's like to live with not only HIV, but other chronic health conditions, and that science needs people to participate so we can push the needle along. This is important because it brings perspective to research conversations, especially around stigma, adherence, mental health, and trusting in the healthcare. And again, that's one of my passions is just bridging the gap. Lastly, I like to educate and empower others. As I stated previously, I'm very involved in our community activities and things like that through advocacy. And I've been honored to be invited to things like this to participate in. HIV is not a crime. Last year, I was able to participate, and I learned so much that I thought I knew and that I did not know. You can always still learn. And the club that I created recently was called the Beyond Red Social and Support Club. And it really, the red is says empowering, reclaiming and empowering dignity. And the whole idea is that patients, I've talked to a lot of patients who nobody in their life knows or they don't disclose. And what I want this to be is a place for us just to meet up. We can come to an activity. We can go to like the golfing range and just hang out there. And you do not have to disclose your status. You just know that the founder of it is positive. And if you want to disclose, you can disclose. And what I hope people will remember is that HIV is lifelong, but so is growth. Treatment is both medical and emotional. Support systems matter. Representation matters, and life continues beyond the diagnosis. Some of the pictures featured here is just from my wedding, my two different run groups over the years. I've been giving presentations with Vive in my different research community as well. I pledged an organization. This lady right here, oops, sorry, this lady right here in the black in my wedding picture was actually my childhood doctor. The Fight AIDS, Not People with AIDS is a wall from the Camp Heartland wall. Um, these are my brothers through the different years, my families, my coworkers over here. My most recent, um, last year I was doing presentations with different people who are involved in the HIV community. It's just very honored. Was able to meet Colin Powell as a child, and then the Auntie Diana woman who helped us get into research as a child. She recently passed, but I was able to still see her through the years, and her daughter is one of my best friends. Um, I also would like to point out that I did know Hadiah, and it is such a loss that it's such a sad and a loss that we lost. I don't, it's so sad that we lost her. And growing up with her was a definite journey. And life does not pause. And she is a true example of that you can continue to live life and be a true example of what beautiful things can occur. We are no longer just surviving, we are building lives. Thank you. This is just one of my wedding pictures and some of my cute little baby. Thank you so
Thank you,
much.
Tia. Thank you, Tia, so much. That was absolutely wonderful. Your baby is just drop dead gorgeous. Like he's beautiful.
Thank you.
And we need to mention that it's been less than 3 weeks. Yes?
Yeah, he was born
Yeah,
April 28th.
less than 3 weeks. So, like I said, she's a rock star for being here, and coming and sharing her life and experiences with us. We just have a couple minutes left. If Ezer and Allison want to come back on real quickly, we are going to stop the recording so that folks can feel free to freely answer or ask questions if they have any in the chat. If you'd like to raise your hand, or put your question in the chat. The slides will be available afterwards. If there are questions or things that come up for you after the webinar that you would like us to answer and or address, maybe before or during the next webinar, then we can definitely do that. I saw a lot of hearts and thumbs up throughout all three of your presentations, which is fantastic. I can't see if anyone has raised their hand to ask a question or not. Does anyone want to come off mute real quick in the last
Bridget,
couple
just
minutes?
real quick, we are recording, but we're not going to share the Q&A publicly. We're just have it for internal purposes.
Got it. Okay. We're going to cut it off. Okay. All right. Questions? Anyone want to ask a question or a thought? I just want to say that there were several things that stood out to me during your presentations, particularly that transitions don't pause in life with HIV, right? They still happen to us. Also that from innocence to culpability, that struck a nerve. And I know that there were a lot of hearts that went up during that time. And so I think that also struck a chord. with folks in the audience. Do any of you have anything that you want to add in the last minute or so before I close us out? Because I don't see any questions.
No, I just wanted to thank Tia for just laying out all the things. It's I I oftentimes say that, I do a lot of presentations about the comorbidities, et cetera, and it's so important to partner the that part with the psychosocial, with the real lived experience. Like it has to be a package, or else, we're thinking about inflammation and what have you, and forgetting that it's people and lives going through their life course. So I'm so excited for how this is going to evolve, and really appreciate Tia. I don't know how she's doing it without passing out with the baby and all the things, but just really excited to see it all together as it should be. So thanks, Ezer and Tia, for partnering on this one and for your moderation, Bridgette.